When was the last time you were in the hospital or in an extended stay healthcare facility like a nursing home or a rehabilitation center? Maybe you were there visiting someone else who was sick, or maybe you work there. But when you looked around, what did you see? Modern medicine employs a number of devices and invasive methods to preserve life while people recover from illness or disease. Unfortunately, for 1 in 31 patients in these facilities, the road to good health will be interrupted by a speed bump called a healthcare-associated infection, or HAI. These fairly common infections are the subject of this video. Your objectives are to define the term HAI, or nosocomial infection, to explain the trifecta of infection, to describe standard precautions and compare them to transmission-based precautions, to briefly describe the 4 most common HAIs in the United States, and to name at least one common cause of HAIs in the United States. Healthcare-associated infections, or HAIs, used to be called nosocomial infections, but the term is falling by the wayside in preference to HAI. These are infections whose development is favored by hospitals or hospital-like environments. These are also infections that are acquired during a hospital visit, so the infections are not present prior to entry to the hospital, but signs and symptoms may appear within 48 hours of admission. HAIs are also defined as infections occurring within 3 days of discharge or 30 days of a surgery. Healthcare-associated infections are usually caused when 3 factors that are common in clinical environments come together, forming what I call the trifecta of infection, or an HAI. These 3 factors are the microbes that are in a hospital environment or hospital-like environment, the compromised hosts that are in the hospital or hospital-like environment, and then your chain of transmission. All 3 of these contribute in some way to the development and persistence of HAIs. One factor that contributes to the development and persistence of HAIs is the sheer number of microorganisms in a hospital environment. Each person that comes through the doors of a hospital or a clinic or a nursing home, you get what I mean, each one has their own normal flora. And many of the microbes that are in the normal flora can be opportunistic pathogens. Remember, opportunistic pathogens are microbes that can cause disease under certain conditions, such as when someone's resistance is low because they're sick. So these opportunistic pathogens on the skin of patients, personnel, visitors, everyone, can be transmitted from one person to another. And when these opportunistic pathogens are transmitted to patients, then patients can become sick. In addition to the number of microbes in these hospital-like environments, some microbes are going to become antibiotic resistant to 1 or more drugs. We call these microbes, these resistant microbes, superbugs. And they become resistant because you have a bunch of potential hosts who are all on different antibiotics. And what typically happens is the weakest microbes get killed by the antibiotics first, leaving behind those microbes that have some inherent resistance to the antibiotics. Then those leftover microbes can exchange genes with each other and create new combinations of antibiotic resistance. So Pseudomonas aeruginosa is an example of a superbug. It's difficult to control in hospital-like environments because it has a lot of R factors. R factors are plasmids that have multiple genes for antibiotic resistance. When these R factors wind up in the same bacterium, then recombination can happen, shuffling those resistances and creating new plasmids and new antibiotic resistant strains of bacteria. Don't forget, in a host, you'll have some bacteria that will do transformation and they can pick up resistance that way. You have some that might do conjugation and transfer resistance that way. You've got viruses, so there's transduction that can happen. So antibiotic resistance can also be transferred that way. So the microorganisms in a hospital or hospital-like environment are major contributors to the propagation and persistence of infection. Next, you have compromised hosts. This is the second part of the trifecta. Patients in a hospital usually have a lowered resistance to infection. Remember, often people don't go to the hospital unless they're really sick. And their resistance to infection can be low because, number one, when we're sick, there's stress on our body, and stress influences our immune system by weakening it. Sometimes people have diseases that can also impair resistance. Sometimes the therapies that people receive in the hospital break down their resistance. One of your best defenses against infection is actually your skin and mucous membranes. As long as they're intact, you have like an invisible barrier or an impenetrable barrier that it's really difficult for microbes to get through. But if you think about different therapies, they might penetrate or damage the skin and mucous membranes, and this makes infection more likely. Sometimes people in hospitals have extensive burns over their body. Again, this is damage to the first line of defense, which makes them more susceptible to infections. Some people in the hospital will also be compromised because they have weakened immune systems. It, again, could be because of stress, it could be because of disease, or maybe it's malnutrition. Someone has been sick, so they haven't been eating the way they need to. They don't have the right nutrients to support the growth of white blood cells and other immune system components within the body. When we talk about weakened immune systems, we mean that the number of B cells and T cells is low and resistance is low as a result. So you have microorganisms in the environment and you have compromised hosts. The third component of the trifecta is the chain of transmission. So this is another way of referring to the modes of disease transmission that we talked about earlier in the chapter, but these are happening in a healthcare environment. For example, antibiotic-resistant microbes that are present can become part of the normal flora for your healthcare workers. Then these personnel can transmit those microbes through direct contact with patients. For example, when they change a dressing. Believe it or not, I've actually seen a nurse change a dressing without gloves. That transmits disease. I've seen dental technicians who, instead of changing their gloves, they're moving around the exam room, touching every single surface that they can, and then they want to go work in a patient's mouth with those dirty gloves. Well, they could have picked up all kinds of antibiotic-resistant microbes and pathogens on the gloves that they're getting ready to work in someone's mouth with. So you can have direct contact with patients that can transmit disease. Other methods of direct contact, maybe someone is looking at a wound, or they're just shaking hands to say, hello, how are you feeling today? I'm Dr. blah, blah, blah. Okay. You also have indirect contact. So these HAIs can be transmitted via indirect or fomite contact. So fomites like doorknobs, furniture, wheelchairs, faucets, meal trays, all of them can transmit microbes from one patient to another, or from healthcare personnel to patients. It's a concern. And then I haven't even talked about those fomites that actually get inserted into people's bodies, like urinary catheters. IV catheters, or ventilators, which also can transmit disease. So it's the microbes in the environment, it's the compromised hosts, and then all of the routes of transmission between staff and personnel in a healthcare-like environment, okay, and patients. And we didn't even talk about visitors. They also factor into this. The only factor of the trifecta that can really be controlled in a healthcare environment is the chain of transmission. We can reduce the number of microbes, sure, but we can't eliminate them. And we can improve the patient's resistance to disease, but that may take time and healing. Thus, disrupting the chain of transmission is the only thing that's immediately actionable and is a primary way that healthcare facilities attempt to reduce or prevent healthcare-associated infections. Universal precautions are designed to protect the healthcare personnel, facility staff, patients or residents, and visitors to a healthcare environment from infection. These precautions are divided into two groups. You have the standard precautions and the transmission-based precautions. Standard precautions are the basic minimum practices necessary to prevent transmission from one person to another. And these precautions include, but are not limited to, robust hand hygiene, so that means properly washing your hands when you enter a room and before you leave, certainly before you touch a patient, and after you've touched a patient. It includes the proper use of PPE. This is personal protective equipment. It includes things like gloves, um, uh, sometimes face masks. It includes wearing the proper clothing and also making sure that you disinfect shared equipment. Respiratory hygiene and cough etiquette is also important. You don't want to breathe in someone's face. You don't want to cough or sneeze in their face either. Disinfecting general equipment that gets used with a patient, and environmental cleaning or disinfection. So you want to make sure that the room that a patient is in is also clean. Transmission-based precautions are those that supplement standard precautions while working with patients who have or are suspected to have infections that are highly contagious or especially virulent. These precautions are used when standard precautions do not sufficiently disrupt the chain of transmission. So there's three general groups. You have the contact precautions, which are used when patients have infections that are spread by contact with feces, urine, skin, vomit, body fluids, or wounds. And some examples of extra precautions that you might need during contact precautions include the use of disposable equipment or dedicated equipment that is only used on that one specific patient, wearing a gown and booties, wearing gloves, and these may be slightly thicker gloves. You also have droplet precautions. These are precautions used for patients who have infections that are spread by heavy droplets that don't travel very far. So usually patients under droplet precautions, they'll be in a private room. Visitors and personnel may have to wear a surgical face mask when they visit, and the patient may also have to wear a mask during visits. Usually, droplet precautions also include the wearing of gowns and the use of gloves. Airborne precautions are used when patients have infections that are spread over long distances. So they're producing those little tiny air droplets, those droplet nuclei that travel really far and hang in the air. So for this case, patients or staff may have to wear that N95 mask that you might have heard of in the news. It kind of reduces 95% of the particles that could be breathed in or exhaled. Someone on airborne precautions can also be using eye protection. And a lot of times, if it's available, patients under airborne precautions will be kept in a room that's under negative pressure so that air from the room does not flow out into the hallway, but rather air in the hallway flows into the room and then up through the ventilation system. So now what I'd like to do is take a look at some commonly reported HAIs in U.S. hospitals. We're going to look at the four main types. We have central line associated infections, catheter associated UTIs, surgical site infections, and ventilator associated pneumonias. A central line, also known as a central venous catheter, is a tube that's placed into a large vein in the neck, chest, arm, or groin of a patient. And usually this device is used to give medications or fluids, or it's used to draw blood for medical tests. These catheters are different from IVs because they access a major vein that's close to the heart, and they're left in place for weeks or months at a time. Because the catheters are left in place for extended amounts of time, biofilms sometimes form on them and become a source of infection. Central line associated bloodstream infections cause serious infections, and they occur when bacteria or some other microbe enter the bloodstream via that central line. These infections usually present with fevers, chills, and the skin around the catheter can become very sore, warm, and red, indicating a problem. The only way to really treat one of these bloodstream infections is the use of antibiotics and then to remove the central line and place a new one. Catheter-associated UTIs are infections that involve any part of the urinary system. This includes the urethra, the bladder, the ureters, and the kidneys. And UTIs, these urinary tract infections, are the most commonly reported nosocomial infection. Approximately 75% of UTIs are associated with urinary catheters. So a urinary catheter is basically a thin tube that's placed in the bladder to drain urine. So as you can see in this image here, the tube goes up through the urethra all the way to the bladder. And this is called a Foley catheter. It has a little balloon on the end that once the catheter is in the bladder, the balloon is inflated a little bit to hold it in place. Then as urine accumulates in the bladder, like you see here, it gets drained out through the catheter into a bag. So infection occurs when bacteria, yeasts, or other microbes from a patient's urinary meatus, rectum, or vagina, okay, or maybe it's microbes from a healthcare personnel's body, get onto the catheter, and then they travel along the urinary catheter to the bladder or kidneys. The microbes often form biofilms on the catheters after they're placed, serving as another source of infection. Typically, these UTIs present with burning or pain in the lower abdomen, fever, bloody urine, or burning during urination, and an increase in frequency of urination after the catheter is placed. Surgical site infections are infections that occur after surgery in a part of the body where surgery took place. The infection usually presents with redness and pain around the surgical site. This may be accompanied by the drainage of cloudy fluid from the site and maybe fever. And then you have ventilator-associated pneumonia. So a ventilator is basically a machine that helps a patient breathe by giving oxygen through a tube that's placed in the mouth, the nose, or through a hole in the front of the neck. As the machine breathes for the patient, air is forced deep into the lungs. Infection occurs when pathogens reach the lungs through ventilator use. Usually these infections, again, are lower or deeper in the lungs because the ventilator usually pushes more air into the lungs than we inhale, and so that air is forced deeper into lung tissue. The longer a patient is on a ventilator, the more likely they are to develop pneumonia. So typically, medical personnel will try to get someone off of a ventilator as quickly as they can. So the best treatment for all of these infections really is prevention, taking steps to thoroughly clean and sterilize equipment, wearing appropriate PPE, and paying attention to aseptic technique. When infections occur, anyways, they can oftentimes be treated with a regimen of antibiotics, but it should be noted that with the rise in antibiotic resistance of pathogens, particularly in your healthcare environments, treatments are becoming less and less effective. Now let's look at 4 bacteria that are major causes of HAIs in the United States. We're going to look at MRSA, Acinetobacter baumannii, Clostridioides difficile, and Pseudomonas aeruginosa. Staphylococcus aureus is an opportunistic pathogen that is present in the normal flora of about 30% of people, where it lives on the skin and in the nares. Usually, as long as it stays there, it doesn't cause any problems. But when the bacterium winds up elsewhere in the body, it can cause serious medical conditions, such as sepsis, when it enters the bloodstream and causes a system-wide inflammatory response. Pneumonia, when it spreads to the lungs of people with underlying lung problems or people who are on ventilators. Endocarditis, when it spreads to the lining of the heart and causes inflammation. In this case, staph infections can lead to heart failure or stroke. And when Staphylococcus aureus winds up in the bones, it causes osteomyelitis, a painful bone infection. This is the same bacterium that you were working with in the laboratory. You might remember that it's a gram-positive coccus and that it's non-motile. MRSA is an antibiotic-resistant strain of Staph aureus, and it's resistant to most of the antibiotics that we would commonly use to treat staph infections, namely penicillin-type drugs that collectively are called beta-lactam antibiotics. There are 2 types of MRSA infection. You have the community-associated MRSA infection. Usually these are infections that are contracted outside of healthcare settings, and they're contracted by healthy people with no history of MRSA infection. You might have heard of people, for example, contracting MRSA at the gym. Typically, it's the community-associated MRSA that they've contracted. This particular type of MRSA is very virulent and aggressive and extremely contagious. You can become infected just by using the mat at the gym or equipment at the gym after someone who has an active infection has used that equipment. Typically, the community-associated MRSA presents as a soft tissue infection. Initially, it looks like an insect bite or a blistery bite with a lot of swelling associated. It can be quite painful, and when the MRSA bacterium moves away from this infection site, it can cause sepsis and pneumonia. Other side effects or signs and symptoms of this MRSA infection include cellulitis, abscesses. It can penetrate and affect muscle and bone. It can affect deep fascia and cause an extremely, extremely painful wound. When MRSA is found in hospitals and healthcare associated environments, then that's called an HA, or hospital-acquired MRSA. And this type of MRSA is transmitted by the hands usually of healthcare workers. So someone, for example, who changes a wound dressing for a MRSA type infection on one patient, then they go to another room and start changing or adjusting the dressings on another patient. That can transfer MRSA. Or maybe it's a MRSA infection acquired from medical devices like blood pressure cuffs, for example, or stethoscopes. Um, the bacterium can persist in a medical environment for days to months, depending upon the environmental conditions. And when someone has this hospital-acquired MRSA, typically they're immunocompromised, which again makes them susceptible to the sepsis and the endocarditis and the pneumonia and those other complications that I talked about on the last slide. So that's MRSA. What you really need to remember is that it is a um, methicillin resistant form of Staphylococcus aureus. Usually it's resistant to multiple penicillin type drugs, and collectively we're going to call these drugs again beta-lactam antibiotics. I will tell you that for a number of years the alternative treatment for people who had a MRSA infection was to receive another antibiotic called vancomycin. And vancomycin, for a while, was able to kill MRSA infections that didn't respond to other antibiotics. Unfortunately, there is now VRSA out there. So this is VRSA. This is vancomycin-resistant Staphylococcus aureus. So these are bacteria that are now resistant to the second line of defense drug, vancomycin. Fortunately, there are other treatments available, and we'll talk about those in Chapter 20. But when someone has a MRSA infection, it can be very, very difficult to treat them for it. Next, we have Acinetobacter baumannii. This is another opportunistic bacterial pathogen, and it infects the weakest of the weak. The bacterium has always been around, but in the early 2000s, the presence of the bacterium surged due to exposures on the battlefields of Iraq, where doctors performed emergency surgeries to save the lives of U.S. service members. Soldiers, for example, became infected. They brought the bacterium back to hospitals on base, and then when those um, soldiers were transferred to other hospitals, they brought the bacterium with them. So they took the bacterium to Germany, they brought it here to the US as well. Now, by itself, Acinetobacter baumannii is not really something to get excited about. It's not particularly virulent by itself. However, this particular bacterium is especially adept at acquiring antibiotic resistance, and this is why it's now a problem. It, through being in healthcare environments, has acquired many, many resistance genes, and it can be very difficult to kill. Because this bacterium infects the weakest of the weak, you have a high incidence among people who are immunocompromised, people who've been hospitalized for more than 90 days, and people who are in ICUs. This is a highly contagious bacterium, and it causes serious infections in the lungs, the blood, and the brain for those who become infected. Many soldiers have had amputations because their various tissues were infected with this particular bacterium. It can also cause wounds and urinary tract infections. Acinetobacterium is a pleomorphic bacterium. It's gram negative, pleomorphic, and non-motile. Clostridioides difficile used to be known as Clostridium difficile. It's also known as C. diff. It's an opportunistic bacterial pathogen. It can live in the intestines of healthy people, where it faces microbial antagonism by other microbes in the intestines. Outbreaks of C. diff usually happen in hospitals and hospital-like environments among people who are on antibiotics. So these antibiotics kill a lot of the bacteria that will compete with C. diff, and then C. diff grows out of control, partly in fact because it's a spore former, and those spores can actually survive the hostile environment produced by the antibiotics. C. diff causes debilitating diarrhea and colitis, and is estimated to cause 500,000 illnesses in the United States annually. About 1 in 11 people over 65 actually die from this. C. diff is a gram-positive spore-forming bacillus, and it's the toxin that it produces that actually causes illness. The last microbe is Pseudomonas aeruginosa. This is another opportunistic bacterial pathogen, and in 2017, a multi-drug resistant P. aeruginosa strain caused 32,600 infections in hospitalized patients and about 2,700 deaths. We tend to find a higher incidence of this bacterium in people who are on ventilators, people who have catheters, or have wounds due to surgery or extensive burns on their body. It causes infections of the blood, the lungs, and other parts of the body after surgery. The problem with Pseudomonas aeruginosa is that it can become multi-drug resistant very easily. It has a lot of R factors in it. Those R factors undergo recombination, and these bacteria are able to use various methods of lateral gene transfer to actually move the plasmids from one cell to another. Pseudomonas aeruginosa is a gram-negative bacillus, and it is motile.